So I'm a pediatrician working in the UK for more than 20 years now. I have a lot of experience, uh, 15, 16 years of experience in pediatric endocrinology, but not specifically in working with children and young people who are exhibiting gender incongruence. I've been asked by Dr. Sanjay to briefly just review the WPATH guidelines and then the UK experience. So what I aim to cover is very briefly the WPATH guidelines. Dr. Kocher has beautifully described the puberty delays or blockers. So I'll just rush through those quickly and then what happens in the UK. Yeah. So the standards of care, the WPATH guidelines. So I've just categorized them into exactly what Dr. Kocher has described so beautifully previously. We have, it's stepwise. So this is when we have passed all that initial phase of mental therapist involvement, family, social interventions. The child has reached a stage when he or she is fully established with his feelings and is very strong that he wants to affirm a different identity to that which was given to that child at birth. So the first stage are the puberty delays or GnRH analogs, and this is a fully reversible intervention. So the purpose of this is both therapeutic and diagnostic. The second phase are the partially reversible interventions where the hormone therapy to masculinize or feminize the body are induced. And then we have the irreversible interventions, which are the surgical procedures. So I think I will just go, this has been covered beautifully by Dr. Kocher. I'll just jump to this slide. Again, Dr. Kocher has described this in some detail. We know the pros. We know that it's therapeutic. A child who's just started puberty has experienced the hormones of gender he doesn't want. If he's going through that phase, he can't focus on what's happening, he or she can, in their body. So it gives, we pause it, we stop it, and let that child experience what's happening. Give that child time to reflect on what's going on. And this phase, I think, is the most important. This is the phase where the family, mental health, physicians, pediatricians need to be really supportive. They have to try and understand the child, try and understand what's going on in the child, encourage the child to express. Child shouldn't be frightened to keep those thoughts inside him or her. And it's diagnostic, because if there's a real improvement in the distress and anxiety a child is facing, it helps everyone understand that, yes, this child, this is something the child really wants. This may lead to long-term, changes. And I think it's really nice to do it at a very early stage, at TANF stage 2. I totally agree with that. It really helps if you do it that early. If the young child or young person proceeds on to really want that, go on to gender reassignment surgery, genital surgery, then it's much easier. But there are some cons against it and some unknowns. We know that with the onset of puberty, average age 10 to 12 years, there's increase in bone mass development and there's bone growth. And if we are starting GnRH analogs at the age of 12, we have to remember some children may start puberty at the age of 9 or 10. That means we are then denying them their bone growth till the age of 15 or 16. But let's assume a child starts at the age of 12. If they go on to say, yes, we want to continue, we definitely want to have masculinized, say it's a trans woman, I definitely want to have feminizing hormones. Then they're about 4 years when this child has, this young person hasn't been exposed to any sex hormones, estrogen or progesterone. We know there's some studies, they're very initial, we have 10 years of data so far that the bone mass is decreased. In that group of children who haven't had, whose puberty has been suppressed, by these blockers for 4 or 5 years, but it can be optimized, make sure they have adequate vitamin D, remain active, do regular bone mineral density scans. We have those T-scores for different age groups, boys and girls. Maybe it'll be fine. So we need more data on that. Certainly, it's nothing that concerning that we should stop using GnRH analogs in 12-year-olds. There's a big concern being raised recently in the UK. As you know, the Tavistock Clinic, the Center of Excellence in the UK, they've had some cases, some families have sued them to say that we have started, we start 11, 12, we are starting puberty blockers, that puberty blockers increase the odds of later medical transition. That is, if they hadn't had GnRH analogs, they may not have transitioned. This can be challenged by the fact that we have so much experience in using GnRH analogs in precocious puberty. Okay. In some children with significant learning delays, I have not introduced estrogen. In a girl, I still remember significant learning delay. She wouldn't have coped with periods. I remember introducing estrogens at the age of 15 or 16, and she's done fine. She's wheelchair bound, but still her bone mineral density is fine. So I don't, so that's about the bone mineral density, sorry, but we know that in children who have precocious puberty and are given puberty blockers, they don't choose to another gender. So there's no substance or evidence to support this claim. The other thing is cost. It's a big, big factor. It is the best. You can use estrogens or anti-testosterones, but GnRH analogs are the best. You have preparations which are given monthly, 3 monthly, there's a yearly preparation, but the cost. So the cost, if it should be subsidized. There's no way everyone will be able to have access to it. And then there are some issues about later genital surgery if they're given earlier. Right, now just briefly touching on partially reversible interventions. Partially reversible means you're now adding in hormones to begin feminizing or masculinizing the particular child or young person. Exactly as Dr. Kocher said, it depends on the age of consent in different countries. In most countries, it's 16. In India, it's 18. But if we have a principle of Gillick competence in the UK, if they may not be 16, but they're mature enough to make decisions, they can consent. Again, at this stage, all the pros and cons have to be discussed. And the effect that will have on them. It needs to be done by experts who have experience. It needs to be done, the British Society of Pediatric Endocrine and Diabetes says it should be about 2 years. So you're saying someone in stage 2 to completion of development stage 5. Process should be very gradual, should be as physiological as happens in us, shouldn't be rushed. But if someone wants it slower, it's fine. We certainly would not do it in a year, from stage 2 to stage 5. And there are various guidelines which you can follow. Each country will have its own. In the UK, we follow the BISPET guidelines. And it's during this phase, they need that support. You know, at each stage, some people may find the changes not very accepting. We say we still want to, a trans woman may say, I still want to remain as my gender identity is still female, but I don't want this. I just want it to stop. That's fine. Stop it there. Okay. And then the irreversible options, which is, of course, genital surgery. I think what's really, really important in the WPATH guidelines, I'm not sure if this is there in the Indian standard of care, Dr. Sharma, but is that you require 2 qualified mental health professionals who have independently assessed the patient. It's so important because this is permanent. It's not reversible. The distress which can happen if someone 5 years down the line says, gosh, I didn't want this. They may still want the same gender identity, but said, we didn't want this surgery. It's tricky, and this is really difficult. So it's just, it's the decision. The processes then are more complex. They're specialized people. But that decision taking needs to take time. It shouldn't be hastened. WPATH say that, guidelines say that the patient should have been living in that gender role for at least 12 months. I feel that should be longer, but, and chest surgery is obviously for female to male patients who have not had puberty blockers at a young stage. They already, breast stage 4 or 5. That surgery is relatively simpler. But there are lots of there's so much advancement in the field, in the surgical field, and it's not my area of specialty, but I think that decision to go forward for genital surgery is the most important thing which needs to be addressed carefully. Right, so the next slide, I'm going to discuss the referral pathways in the UK. I have, it's actually a photograph so in 2013, the NHS submitted, commissioned a service. They said, I'll just get to the first one. I had real troubles getting a heading onto this, but prior to 2013, I know in London, because I was a registrar then working in that team, they had a sort of multi-professional team involved with pediatricians, pediatric endocrinologists, psychologists, psychotherapists, urologists, gynecologists, who would see a patient together and provide support. Okay. Then there was there was an increase. There was greater awareness of this, greater referrals. So NHS said we need to commission a service. So these were the commissioning guidelines. And as you can see, it's still GIDS. It should now be gender incongruence of childhood. So this was the pediatric referral pathways, which were commissioned. And currently, there was a plan to commission 2 services, one in London, one in Leeds. Eventually, a center of excellence was commissioned in London, the Tavistock Center near Charing Cross. And then it set up 2 sort of satellite centers, one in Exeter, one in Leeds. Okay, and this was their plan. They said that the referrals will come in from primary care first. So the first pathway is just reviewing the initial referrals. So a referral is received by the GIDS team. It's discussed by the team. So the important things here are age cutoffs. If someone is 17 years old, they're going to have a chat with that person. Do you want to continue along the pediatric pathway? It may be better to go along the adult pathway, because a 17-year-old would have completed the pubertal development. So it's better to go, and the general advice will be go to the greater than 18-year-old pathway. We can support you till then, but the intervention will be done by another team. Sometimes there isn't sufficient evidence. A child is expressing some things, the GP isn't sure, they'll say, right, get this assessed. So in the NHS, the pediatric psychology team is called CAMS, Community and Adolescent Mental Health Service. The GPs are generally advised to have that child and family assessed by the CAMS team before the referral comes. They'll do all, and these are teams who are very trained in assessing children with gender incongruence. So they have done the assessment. They feel, yes, strongly this child has those feelings. Let's refer to Tavistock. So all that assessment is done. Then after the assessment, all the information has been obtained. Then weekly, they would meet up, because I've attended some of these meetings. They would review the referrals and say, right, this is what we need to do. This child needs a 3-monthly review in our clinic. This is just children, maybe 9, 10, maybe a bit older. This child needs a 6-monthly contact, or this child actually needs to be referred to the endocrine section of the GIDS clinic. Okay, and this is the endocrine pathway. So the GIDS clinic will normally refer to this pathway, or it will come from pediatric endocrinologists like me. You know, someone who has, or a GP who has already seen the child, assessed the child, has had all that input. Okay. So they'll do an appointment. So the appointment may be directly with a group with endocrine, or it may be with a group with a GIDS clinician who is not necessarily an endocrinologist. Okay, I'm sorry, I'm using the old terms here. And that team is brilliant. There's a nurse, There's a psychologist. They may be, we call them social workers or family support workers who have been working with this family. The child, young person, sometimes they bring along a friend rather than a family member. And if they've decided, yes, this particular child will proceed with puberty blockers, DNR analogs, all the investigations are done, assessments are done. If it's a slightly younger, I've seen 10-year-olds, who feel so strongly. I remember sitting in one clinic and they started at the age of 10, that child was Tanner stage 2 to 3. Normal, a bit early, but so all these investigations are done. And then the prescription of GnRH agonist is done. Triptorelin is used in the UK, is done by GPs. So we have shared care guidelines with GPs. They will prescribe it. In our trust, one of our community pediatric nurses will go and give the injections at home. So different trust. So this system is and it's all funded. As long as there's this is a commission service, family pays nothing, And then the GITS team will review them 2 to 3 monthly, review the treatment, and then there's constant, at the same time, they're being put in touch with peers, with going through this, there are social groups, networks, the families join, and then eventually they're taking regular follow-up. A few years down the line, they want masculinizing or feminizing hormones, those are started, and they have been started as young as 15. And at any stage, and the important thing is a reassessment at each time. At any stage, the child or young person says, hold it. I think this is enough. You can stop it. You can stop it. At any stage, you can stop it. Sometimes, so it's really important. And that's where that initial assessment and the CAMS involvement, a small percentage of these children may actually be on the autistic spectrum. They're very high functioning, they're Asperger's, and they don't understand, they're confused. And it's just how you speak to that group of children to try and understand what's coming. They may have like everyone in the community, there may be some psychiatric issues, and they don't know what's happening. They just want it, and suddenly realize no. Or suddenly they realize, no, we don't want to go that far. That's fine. And then this clinic is offering services up to the 18th birthday. Then it's transfers to the adult team. They're very well. So adult team, there are massive amounts of services. We have, in England itself, we have about 8 centers offering transgender services, endocrine and surgical. In Scotland, in Wales, there are at least 2. In Scotland, there are at least 3. There are many, but the pediatric ones where I feel most of the focus should be is lacking. Okay, just wanted to let you be aware of this NHS rainbow badges. So these were started about 5 years ago by a pediatrician in Guy's in St. Thomas's, who himself is actually gay. And he said, people need to know that we are a gender-friendly, LGBT-friendly team and society. And gradually, more and more trusts have linked into the scheme. But to be eligible, so our trust linked into it about a year ago. We had an email, right? If you want to wear these badges, this is what you need to do. So you just don't wear the badge saying you support LGBT, but you wear the badge. If you can, people can come over to you and ask. In a corridor you're walking, a parent will come over to you and ask, right, my child, where do I go for support? Where do I even start? So like mentioned here, if you see anyone in the NHS, it could be a porter, it could be a domestic, it doesn't need to be a doctor. Wearing this badge, they've made an informed choice to do so, okay? This means you can trust that they are a friendly, willing to listen without judgment, and will know how to signpost to the support available. So don't be afraid to talk to them. So I was just thinking something similar, your brilliant team, Dr. Sharma, could set up. I don't know whether it should be there in government hospitals, schools. We have different badges in education, but this is for the NHS. After COVID hit us, we had rainbow badges, but that's different. And this is very different. So, yeah. Thank you.
Thank you for that brilliant presentation, Nandita. And this concept of having a match which shows the person that you are friendly, this is something that I think we need to adopt, and we need to really enforce in all our healthcare facilities, in our education facilities. And Nandita, let me inform you and the audience that ATHI is thinking on the same lines. And we have launched 2 online certificate courses free of cost, which talk about gender education. And there are 2 of them. One set is for parents, teachers, educators, and lay people, and it just teaches them as to how to be gender friendly. It gives a 360 view of what community wants, what is the current thinking of the education is, what are the policies, and it is our small effort of saying that yes, if you have this badge on your institution, if you say that your institution is gender friendly, then it makes a lot of difference in the way you treat a person who is afraid to step into the healthcare facility, or who drops out from an educational facility. So, hence, both these important group of people, the doctors or the medical professionals and educators, we have tried to address them. It is so heartening to see that if we persist, this is really going to work. We'll take a cue from what you have told us, Nandita, and I'm sure we have so many participants who are listening to us who would help us take these initiatives forward.
Can I just add a word, Dr. Sanjay? I think, India, what we need to do is, we see in NHS, I worked in UK, in Gosh for years, but, their system is slightly different. NHS looks after so many things. And it's an organization which is from the top. Okay, this is what this is. Which is not there in India. We have a government institution, we have private sector, we have, practicing physicians, they have their own clinics. So I think unless it comes from the government level, putting up an NHS badge or making it, some Indian badge will not make a difference, because it has to come from that. Like Sanjeev mentioned, I think it has to come into the books, it has to come into the curriculum. People should get more of it.
Absolutely.
UK is a very small country, and then with this NHS is a strong team. This medical system is there, and it's mostly run by Indian doctors there, the NHS. Absolutely. It's run by Indian doctors. So they are aware of this and they are spreading this. Whereas in India, we do not have, because the government has to make some policy. Okay, this is good. 2019 legislation was made and, you can do it. But basically they have to put into the medical system. They have to make clinics, a gender clinic has to come first of all.
Absolutely.
Their gender clinic has to come. 2 clinics in Delhi, 1 clinic in Aligarh, 1 clinic. At least the major cities have clinic. So people will start going to the clinic, and then people will get aware of it. Okay, there is a clinic like this happening in our places, and that there, we are be able to go there. So therefore, the government has to introduce, as if they're having they have a cardiac clinic, they have an endocrine clinic, there must be a gender clinic, at least 1 clinic in each city, so the people know where to go. There are so many children in the rural population who have this issue. We don't even know about it.
Absolutely.
It's you know, because we are in the urban city. We're sitting in Delhi, or we're sitting in, Aligarh or someplace where people are educated know it. There's so many villages where children are having this problem. They are being beaten up by their parents. They're forced to do wrong things. It's just, which is not there with the UK NHS. It's different because NHS is going to the small level also. You'll get it everywhere. Small. So I think what we need to is more and more, put to the government, at least have 1 clinic in 2-3 clinics in India at least, where people know. Then you put up to the website, you put it on the net, you put it everywhere, that there are gender clinic. this is where you can go and take support and help. So those
Good.
gender clinics certify that this child is suffering from, gender dysphoria or incongruence. So they will then, tell, okay, this is there, this is there. Then, so wherever the child goes, people know, okay, that he has to be treated like this. So because, I don't know, because the system is so different in India, you want to go, not going to be easy, like to get a badge of NHS and,
No. I'm just giving an example of ways to spread information about
They've
it.
made it
That was
system
all. It's
actually.
not that you
they've
use a
made it-
badge of NHS. So
no, I
in
mean, the
India-
system is there, but Nandita, this system cannot come to India
Yeah.
very easily. So
No,
Sanjay has to put in, Sanjay has to,
Yeah.
I think what Dr. Sanjay and ATHI are doing is brilliant.
The saying is
Already
perfect
spread
in India.
messages among the school. Yeah, sorry, Sanjay.
Eyes do not see what the mind doesn't know. So India mein to yahi ho raha hai. Unless we know it, we can't diagnose this.
diagnose it. Yes.
Yeah.
So I think that is very important. People should know it first.
And the other thing is the cost. How will poor people afford,
No, Nandita, there is CGHS.
Funded by the government will be
No.
brilliant.
There is CGS in India, it is free. ESI in India, it is free. I have
Aayushman.
lot of patients who are on this GNRH. Everybody is getting it free because ESI is free, CGS is free.
I didn't know that. Okay.
All this are these,
Even Ayushman Bharat must be
Ayushman Bharat,
including
it is
this. Yeah.
free.
Yeah.
I
Lot of
don't know
places you
these
get it free now.
policies. Sorry, I should because I've been away too long from.
Yeah. Yeah, that's the truth. So I think Sanjay wants to say something. Yeah.
It's really exciting to have the pediatricians, agreeing to something, because most of the times what happens is that people have such diverse views, and we all agree that this is a subject where we first need to learn.